Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. Advances in breast cancer treatment and a team approach to care have helped improve outcomes for patients. Together with the Rutgers Cancer Institute of New Jersey, the state's only National Cancer Institute designated comprehensive cancer center, RWJBarnabas Health offers the most advanced approaches to cancer treatment with dynamic teams of cancer care specialists and researchers. During today's show, we will hear from a breast cancer survivor and her treatment team. We are pleased to welcome Aimee Roehler, breast cancer survivor, Dr. Lindsay Potdevin, a surgical oncologist in the breast cancer program at Rutgers Cancer Institute of New Jersey, and at Robert Wood Johnson University Hospital, Somerset's Steeplechase Cancer Center, and Dr. Medela George, Associate Program Director, Breast Cancer and Medical Oncologist at Rutgers Cancer Institute. Welcome to the show. Thank you all for being here. So for the audience themselves, they want to know a little bit about your background. So we'll start with Dr. George. Tell us a little bit about yourself, where you're from, and medical school training, and what got you to RWJBarnabas Health.
So I'm Medela George. I'm one of the breast medical oncologists at the Women's Center at the Rutgers Cancer Institute of New Jersey. I did my medical school at Rutgers Robert Wood Johnson Medical School, and then went for my residency at the University of Massachusetts and did my fellowship at Rutgers Robert Wood Johnson Medical School, and then I decided to stay on as faculty at the Cancer Institute. We are part of a multidisciplinary team at the Cancer Institute, and I work with the surgeons, the radiation oncologists, and other services to help support and treat patients diagnosed with breast cancer.
And it is the state's only NCI accredited comprehensive cancer center, so thank you. Lindsay, can you tell us a little bit about yourself?
Yes, of course. So my name is Lindsay Potdevin. I'm a breast surgeon at the Rutgers Cancer Institute of New Jersey. I have offices both in New Brunswick and at Somerset. So I did my medical school also like Medela at Rutgers Robert Wood Johnson, and then stayed on there for residency. I did go down to Georgetown University MedStar for my breast surgery fellowship, and then came right back up to New Jersey to keep working.
Thank you. Thank you both for being part of RWJBarnabas Health and the Rutgers Cancer Institute.
Of course.
Aimee, tell us a little bit about yourself.
Yes, my name is Aimee Roehler, and I'm from White House Station, New Jersey, and I am 48 years old, and I have my own social media communications business where I work out of my house. And I also play competitive racquetball. I've been playing for 30-something years. I've traveled all over the world representing Team USA in international competitions, and it's great and keeps me active, and I love playing.
So we're going to start with Aimee. Tell us a little bit about what happened in 2021.
Yeah, so I just went in for my annual mammogram, and they wanted me to come back and have a second look. It was nothing out of the ordinary for me. Over the years, I have dense breasts. So I've always had to, not always, but I've had to go back for another mammogram. So it wasn't anything surprising. They asked me to come back for an ultrasound. Again, I've had that done before. But then when I got the call that they wanted me to come in for a biopsy, that is when, it was concerning, and that's when everything started happening.
And just so everyone knows, women should be getting their annual mammograms done starting at age 40.
Yes.
And it's very important that they do that. Places such as the Steeplechase Cancer Center or at the Rutgers Cancer Institute are terrific places to have it done. It's something that's very important for prevention, for picking things up early, because if we pick things up early, we have success. So Dr. Potdevin, tell us what happened.
So when Aimee had her callback imaging, they usually will do additional mammogram views, ultrasound views, and in her case, they found what they called a distortion, which basically means that the tissue architecture on the mammogram, it just looks different, it looks distorted, sometimes it can almost look like a starburst pattern. And that's, a bit of a red flag that there, could be a cancerous process or something abnormal growing in that area. So when we see things like this, the next step is typically to get a biopsy. So oftentimes patients will come to see me when they have this finding, and then we'll talk about the options for the biopsy and how that process will go. So that's what happened in Aimee's case. I saw her before the biopsy. We talked about the process, we talked about the possibilities of what we might find, and then we made sure that we got her set up to have a prompt biopsy so that we could get ourselves a diagnosis.
This is not always the case.
Correct.
Very frequently, especially because in New Jersey that you have to do breast density measurements on a woman, there are many times when you've done the screening mammogram and you get that call back that says we need to come back in for either more for a diagnostic mammogram and or ultrasound if needed to check for the breast the density. We sometimes do see distortions. We sometimes also see what's called asymmetry between the left and the right. Just because there's asymmetry, that does not necessarily mean that there's something absolutely there. It means that the radiologist is concerned. And if he's concerned, he wants more images to see what's going on. And then based on those images that he sees, that's when he may make the referral to someone like Dr. Potdevin so that she can then assess what's going on. So tell us what went on.
So Aimee went for a biopsy, and unfortunately the results did show a breast cancer. So, as soon as we had this information, I called Aimee, let her know about the information that we found, and then we arranged for a follow-up visit so that we could talk really in depth about all the details. Because I always tell patients, the biopsy doesn't just tell us that it's cancer, it also tells us a lot of details about it that can help us guide our treatment approach. And as we discussed with Aimee, and when we spoke, I think we talked about there's not just a one-size-fits-all approach. There's really a lot of different treatment options, which is one of the nice things about breast cancer. We do have a lot of things, a lot of tools in our toolbox to help give patients the best outcome. But it really depends on exactly what those findings are from the biopsy that help us determine what those optimal options are going to be.
So let's hear from Aimee. This is very, very tough.
Yes.
You have the mammogram done, you're called back. As I said, a lot of women get that call back. Number one is the wait to get the repeat ultrasound, get the repeat mammogram and the ultrasound, and then to wait for the report. The report comes back as a distortion, and you're told we need a biopsy. How do you feel?
I think how any woman would feel. That I was freaking out. I left after having the biopsy, and I remember sitting in my car crying because at that point there was a good indication that it was breast cancer, and that was before we had the results of everything. And I remember calling my stepmother. She's a nurse. She lives in Pennsylvania, and she was just somebody I could talk to and rely on and things like that. And it's very
devastating.
It is, because you just don't know. Okay, first thing I'm thinking is chemo. I'm going to lose my hair. I'm going to lose this. Can I do this? Can I do that? And there's just a million things going on. And at that time I was in the middle of a divorce, and just millions of things going on at the time. So it's a lot to take in. It really is. So, yeah.
What was the next step, and what did she need?
So once we had the discussion about, the fact that it was cancer, what type, what our treatment approach would be, we always talk about, our multidisciplinary approach. As Dr. George had mentioned, we work with a bunch of specialists, so the surgeons, the medical oncologists, the radiation oncologists. So we spoke with Aimee about, all the potential ways this could go. And, one of the first things I wanted to do in Aimee's case was then get her an MRI, which is not a test that necessarily everybody needs to get when we have these findings. But for certain subtypes of breast cancer, as well as when patients have dense breasts, sometimes a mammogram and ultrasound might not give us the full picture. So I did want to start with an MRI before we proceeded to any kind of surgery, so that we made sure that we weren't missing anything elsewhere in the breast or in the opposite breast. So when she had her MRI, I unfortunately had to give her another phone call and say, well, we found another thing that we need to address. So in a separate part of Aimee's breast from where we found the initial cancer, we found an area of abnormality on the MRI that also needed a biopsy. So then she had to go for a second biopsy, which also showed a type of cancer, a little bit different from the initial finding, but another type of cancer. So that then told us that we had several spots within her breast that we had to address. So when that became very important to factor into our surgical plan. We typically tell patients when it's a confined, single site, we can usually remove just that part of the breast with a lumpectomy, and that's perfectly adequate treatment. When we're dealing with cancers that are in multiple parts of the breast, we sometimes have to then think about a mastectomy instead as the best option. So that's kind of where it went in Aimee's case once we had these additional results that unfortunately saving the breast was probably not going to be the optimal approach for her.
And again, because you are part of the Rutgers Cancer Institute and have the multidisciplinary team, we're able to do this type of thing and do it along with a medical oncologist on there also.
Yep.
20 years ago, it was basically everyone was getting full mastectomies, and we were going for sentinel nodes and things like that, and women were, we weren't thinking long term what the psychology was going to be on that person, because she's going to be around for another 50 years. We've got to make her life worthwhile. Now that we have lumpectomies and other type of procedures, yes, we have that option. However, unfortunately, in her case, we were unable to do that because of the two different type of cancers in two different spots, which again means that we now get the medical oncologist involved, correct?
Yes, that's correct. So after Dr. Potdevin met with Aimee and we had the results of her both biopsies, we discussed her at the multidisciplinary tumor board. So the question for the medical oncologist is, should we consider any treatments before going for surgery, or should we do treatments after surgery? For certain subtypes of breast cancers, we do consider and strongly recommend doing treatments before surgery. But for tumors that are driven by the reproductive hormones in women, like estrogen and progesterone, we can consider treatments after surgery. We do consider treatments before surgery if there is a chance that we can convert a non-operable breast into a lumpectomy. But in this case, since there were tumors on two different quadrants, it was not possible to do a lumpectomy. So based on the discussions at the tumor board, after reviewing it with the radiologist, the pathologist, the consensus was to proceed with a mastectomy and then consider treatments after surgery.
Which again, important part being part of the Rutgers Cancer Institute is you have the tumor board.
Correct.
Where everyone gets involved, everyone gives their opinion, and we're able to come up with the best means to treat this and have the person recover from this.
Correct.
It's not one person making a decision saying this is what you have. Again, I've been in practice since 1984, and when things happened then, basically I'd send them to the breast of the person. They'd do the full mastectomy with the nodes, with the sentinel nodes, and they said, this is what you have to do. Instead, what we're getting is 20 different people thinking it from different perspectives, giving the best possible procedure and making it so that it's going to be successful, and at the same time explaining it to the patient so that she's well aware of what the process is.
Correct.
So when this all came about, how did you feel, Aimee?
I think they both can attest. I was just like, okay, let's get it done. Like, I remember we were talking about surgery and I had nationals, and I'm like, okay, I need to have this surgery done now so I can recover and be ready for nationals in a month. And Dr. Potdevin, you looked at me like I was nuts, but you were like, okay, let's get it done. And
we figured it out.
Yeah, we did. I had my surgery, and I think 3 weeks later, I was on the court, lightly hitting. I don't think I told you that, but I was. And,
I knew you would.
And yeah, I wanted to get started. I just felt like I had the nationals and I wanted to prepare for that, but I also didn't want to delay treatment because I just felt like, okay, I have cancer. Like, I need to get started on this as soon as possible. So, yeah, so it was just like, okay, let's go. let's get this started.
Well, congratulations on getting to nationals 3 weeks after
Thank
having
you.
a mastectomy.
Thank you, thank you.
And even with light hitting.
And that's one of the things that we certainly factor in, with our tumor board discussions. Number one is, what does our data show? What are the guidelines say that we need to do? But the second part of that is, well, how does the patient feel about this? What's her lifestyle? What's going on with her? And sometimes, the standard of care doesn't make the most sense for a particular patient, just depending on what they have going on.
It's not that the standard care doesn't make sense, it's that we modify it a little bit in order to meet her social guidelines and what her life is.
Right.
I mean, I'm a lefty, so
Lefty.
the cancer was in my left breast, so that was a huge factor. Even when I had radiation, the radiation would tighten up the skin or something like that. So it was always a factor of going into anything and any treatment in the future. So
she got chemotherapy, correct?
Yeah, so I met her after she had the surgery. So the decision to give chemotherapy is it's just not just made by the oncologist. We use genomic tests to help us understand what is the risk of this cancer coming back, how aggressive is this. So we did the genomic test on Aimee's tumor. A test is called Oncotype. And based on the Oncotype results, the size of the tumor, the amount of lymph nodes that had cancer, based on all this information, we decide whether chemotherapy is needed to reduce the risk that this cancer would come back. So I met Aimee after the surgery, and based on all this information, we decided that chemotherapy was the best approach to reduce the risk of this cancer coming back. But she had nationals coming up, so we couldn't give her chemotherapy right away. So we had to see what is the best way to get her to the nationals and then be able to start chemotherapy at a reasonable time point. So Aimee's tumor was driven by estrogen and progesterone, and in premenopausal women, we consider ovarian suppression. It's a medication that can be administered to shut down the ovary so that the estrogen and the progesterone production does go down, as not feeding any small cancer cells that can result in this cancer coming back. So we used ovarian suppression, and then Aimee was able to go for the nationals. And then after she was done with her tournament, that's when we started the chemotherapy. What
do you do to help mitigate side effects? And tell us a little bit about this scalp cooling, which can also help mitigate the effects.
So chemotherapy is not an easy journey, especially because it has a lot of side effects, and hair loss or alopecia is one of the major side effects with most of our chemotherapy regimens that we use for breast cancer. So scalp cooling is a method that has been tested, and right now it's being approved by Medicare to help women reduce the risk of alopecia. It does not completely prevent complete hair loss. It's basically cooling the scalp before chemotherapy is given, and as well as after chemotherapy is given, and during the process as well, so that that area is cold enough and the chemotherapy is not affecting the hair follicles and not resulting in hair loss. So that we had talked about it with Aimee, and she decided to use the scalp cooling. How was your experience using the scalp?
It was cold, I will say. It was very cold. It does extend the chemotherapy time a little bit, because you have to use the scalp cooling before chemo begins and then after. I'll be honest, I probably lost about 60% of my hair, but it did grow back, as you can see, quite quickly. So I would encourage, if anyone has that opportunity to use the scalp cooling during their chemotherapy, I would definitely do it.
Again, part of Rutgers Cancer Institute thinking about things like that. Not something that many people would probably think. They would just say, you're going to lose your hair.
Yeah.
So tell us also about, since this is all part of the Rutgers Cancer Institute, tell us about what a nurse navigator meant to you.
Having a nurse navigator was definitely helpful with just questions I would have on having my port put in, or just the overall treatment and side effects I should be prepared for. and things like that. So it was definitely helpful having the nurse navigator there. I will say Simona was amazing in helping me with everything. She, anytime I had a question, I could text her and she would immediately be on top of it and help me. And I was really grateful for Simona in that aspect of everything. So
part of RWJBarnabas Health, both at the Steeplechase Cancer Center and as well as the Rutgers Cancer Institute, is having a nurse navigator. There you're in. They're the one who'll give you their cell number, who will text you, will make sure you get to your appointments, will make sure you understand what's what. You know, when someone goes into, especially a biopsy, and the word cancer said, they hear nothing else after that word cancer. When you're in the recovery room and they're telling you this is how you do this, you hear step 1, you don't hear step 2, 3, 4, 5, 6, 7, 8, 9, or 10. When they make an appointment with you for coming back in 2 days because the surgeon wants to see how everything is coping, they're the ones who are helping to get you that appointment, making sure, because if you call the surgeon's office yourself, you may not, the front desk may say, we'll see you in 2 or 3 weeks. So having a system such as RWJBarnabas Health and the Rutgers Cancer Institute allows you to get the best optimum quality care available and to get it in a timely fashion and in a place close to home. Those words are very, very important. You did not have to travel 1.5 hours into the city, try to find a parking spot where you can't find a parking spot, put money into a meter, run into a place, be told, and the person's out of the office already, and you didn't hear a word that they said. Instead, you were treating like a human being, and you were given optimal care, quality care.
absolutely.
So tell me other resources that are available. Oh, how did everything turn out? I didn't even ask you all that.
Everything turned out great. I mean, I obviously finished chemo, I finished radiation, and you know, I'm just enjoying life and playing racquetball and enjoying the summer, even though it's very hot outside. And yeah, everything's good.
So have we participated in racquetball tournaments?
Yes, I will be heading to Las Vegas in 3 weeks for another tournament. So yeah.
So it was.
Yes.
So it sounds good.
Yes. Yes. Still very competitive play.
Good. So tell us other resources that are available for patients at the Rutgers Cancer Institute.
So in addition to standard of care treatments, we have multiple clinical trials that we offer our patients. Being an NCI designated cancer center, we have specific trials that are open to comprehensive cancer centers. So whenever a patient is seen, in addition to standard of care, we always consider clinical trials, whether it be new drugs that have shown success in the metastatic setting, and we're trying it in early stage breast cancer, or early phase clinical trials in phase 1 settings. So patients have access to these clinical trials. That's a big thing. And then support services. There are social workers that see the patient in addition to the nurse navigators. There are nurses who do the chemo teaching, who help with the side effects. So we try to provide as much support to the patient. We know this is not an easy journey. Providing counseling, providing grants, application to grants. Sometimes patients have financial difficulties while going through their treatment, so we help them find grants that are right for the patient and help them apply for those grants to help them be supported while going through this journey.
So again, the importance of being the New Jersey's only NCI collaborative with a comprehensive cancer center down at Rutgers Cancer Center. You have things that you're able to offer people that aren't available to just the regular oncologist. You have the tumor board, which really is very important. And a lot of people don't think that it's really important, but it is. You collaborate with everyone there. You know, maybe someone has just read an article from Sloan Kettering that something is going on, and they bring that to the table. Maybe the surgeon just learned a new technique. You know, maybe they learned how there's some type of cancer, that there's a breast sparing procedure that can be done. You bring all of these minds together, and at the same time, you bring the social service in also. And whether people believe it or not, that actually sometimes is just as important as the treatment itself.
That's correct.
Absolutely.
Not having to drive into the city and find a parking spot and put money in the meter and be yelled at by the policeman and have to sign in here and sign in there and go up and then come down. And then if you need to come back multiple times for chemotherapy, makes it very, very difficult. You're here. The Cancer Institute and Steeplechase Cancer Center in Somerset are here. You have the ability to actually be part of your family while you're doing all of this. And that can make a big difference in your recovery.
Yeah,
Thoughts?
that's correct.
Thoughts?
Yeah, no, I agree. I think, being in New Jersey, a lot of us are native New Jerseyans. I grew up in Morris County. I live nearby. Radula has spent a lot of time in New Jersey as well.
Yeah.
She lives not far. So it feels a little bit, I think, more humanistic. Like, we're all humans. We're all here to kind of help each other. And we want the patients to feel like we see them as humans. We don't just see them as a case or as a cancer. We see them as humans, and we take that into account with our treatment planning. The whole person is what we want to make sure that we're addressing, not just just the cancer.
So, Aimee, any words of encouragement for people?
I would just tell women to get their mammograms, to do their breast checks that they need to do, or check their breasts and things like that. Don't put off getting their mammograms. I was just going for my yearly mammogram. I didn't have any lumps or bumps or anything to be worried about. It was just a yearly checkup, and I had breast cancer, so it's just very important for women to get checked.
Important, especially after COVID, when everyone was scared to come in and get their mammograms done. COVID, unfortunately, put off screening for 2 years.
Yes.
It's, we're talking about breast cancer, but it's the same thing with colon cancer screening and lung cancer screening. Now that we're back to where we are, it's very important to go back. One, see your primary care doctor, get your blood pressure checked, get your cholesterol checked, get your sugar checked. Go to the mammogram, get the mammogram done. Go to your gynecologist, get your gynecologic exam. If you're a smoker, stop smoking, and if you can't stop smoking, call up RWJBarnabas Health and get into the Smoke Enders program. And understand, if, God forbid, something happens, we are in the midst of an NCI a comprehensive cancer center. We have some of the most terrific people, most terrific physicians, social workers, physical therapists, etc., here, all together at one place that can give you the right way to be treated. Use them. You don't have to be running all over the country to do it. You have the right people right here. Use the local people.
Yes, I agree.
Absolutely.
Dr. George, any last thoughts?
No, I agree with everything that was said. Definitely get the yearly mammograms. We're seeing an uptick in the breast cancer diagnosis, especially since COVID, since people put off getting their yearly mammograms. So definitely get the yearly mammograms. And if there is anything suspicious, reach out to your doctors. They can refer you to see one of the breast surgeons, and if needed, a medical oncologist if it's absolutely necessary.
And Dr. Potdevin?
Yeah, no, early detection saves lives. So I agree with everything that they said. That's the moral of the breast cancer story.
Thank you all for being here. Congratulations, Aimee. Hopefully you continue to represent the United States at nationals and continue the racquetball that you're doing. Do you want to tell us about the shirt you're wearing?
Oh, so when I was diagnosed, I shared my story with the racquetball community, and I wanted to, first of all, I shared it with the community to raise awareness, but I also wanted to raise money to help the cancer center at Robert Wood Johnson. So we raised close to $7,000 with the Roehler racquetball Awareness is Key shirt, and the money was given back to the patient center, which that money goes towards the cooling caps that we were talking about. It goes towards help for meals for chemo patients, cancer patients. Maybe they need an Uber lift because they have no one to take them home after chemo. So the money that was raised goes back towards that. So that's where the shirt comes from.
Thank you, and thank you for what you've done. Thank you all for being here.
Thank you.
Thank you.
Thank you.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 844-CANCER-NJ. For more information about breast cancer services at RWJBarnabas Health, please visit us at www.rwjbh.org/cancer.